73%.
Yeah, that number is just wild.
It really is. In a recent survey of divorced women, nearly 3/4 of them pointed to one single biological event as the primary reason their marriage fell apart.
Right.
It wasn't infidelity, it wasn't finances or in-laws or, growing apart over different hobbies. It was menopause. So today, we are exploring why a biological transition that happens inside one person's body, well, why it has the power to completely detonate a partnership.
It is a staggering statistic, like you said.
Yeah.
And it highlights this massive blind spot we have culturally.
Oh,
We
totally.
tend to view menopause as this isolated individual medical event. But the reality is, if you're in a relationship, menopause is happening to both of you.
Yeah, it's a shared experience.
Exactly. You are both on the same dance floor, but suddenly the music changes, the tempo shifts completely unpredictably, and neither of you is handed the new choreography.
Okay, let's unpack this, because our mission for this deep dive is not to read you a clinical textbook about anatomy.
No, please no.
Right. We've brought together insights from medical guidelines like NICE and the British Menopause Society, along with relationship data from charities like Relate and actual psychosexual therapists.
Right. Getting the relationship side of the data.
Exactly. To answer one crucial question, how do fluctuating hormones fundamentally reshape connection, communication, and intimacy between partners?
It's such an important question.
It is, because whether you are navigating this transition yourself right now or supporting a partner through it, or maybe you'll eventually face it in the years to come, understanding this dynamic is literally the difference between a relationship crumbling under the pressure and one that emerges, significantly deeper and stronger.
Absolutely. And to truly grasp that relational strain, we have to look under the hood at the underlying mechanism.
Right, the biology.
We need to understand the why behind the behavior. So the menopausal transition lasts, on average, anywhere from 4 to 8 years.
8 years, wow.
Yeah, it's a marathon. And during that time, a woman's body undergoes what is essentially a hostile takeover of its baseline chemistry.
A hostile takeover.
That's really what it is.
Yeah.
We're talking about a severe, often really erratic drop in 3 major hormones: estrogen, progesterone, and testosterone.
And what's fascinating is how those purely physical changes, instantly hijack the psychological state.
Oh, completely.
Take something like hot flushes and night sweats. Culturally, they're treated almost like a punchline, right? Oh, I need a fan in the bedroom. Ha ha.
That's the classic sitcom joke.
Exactly. But when you look at the mechanism, those night sweats cause severe chronic sleep disruption. You are waking up drenched, your heart is racing multiple times a night, and this goes on for years.
Which naturally feeds directly into profound exhaustion and anxiety.
Oh, I see.
But there's an even deeper chemical reality at play here, specifically regarding estrogen. Estrogen acts as a master regulator in the brain. It's deeply involved in managing serotonin, which is, our primary mood-stabilizing, happy chemical. And at the same time, it helps keep cortisol, our primary stress hormone, in check.
So wait, when estrogen plummets, the brain's internal thermostat for stress just breaks.
Precisely. The serotonin levels drop, so you lose that calming buffer, and cortisol just spikes.
Yikes.
The brain is quite literally flooded with stress hormones. This is the physiological root of brain fog. The brain is operating in a mild fight-or-flight state.
Wow.
Yeah, it's struggling to reroute basic cognitive processes because it lacks its usual hormonal fuel.
That makes so much sense of a specific symptom I've seen described in the sources as the shark tongue.
Yes.
Imagine walking into a slightly messy kitchen. Normally, you might just sigh and, load the dishwasher.
Sure.
But with high cortisol, low serotonin, and chronic sleep deprivation, that same messy kitchen triggers a systemic alarm.
It's a threat.
Right. It's not that someone suddenly desires to be hurtful to their partner. It's that the neurological filter that usually says, hey, maybe take a breath before you speak, that filter is completely offline.
The impulse regulation is just compromised. And alongside this neurological shift, there is a very localized physical reality we have to discuss. The medical community calls it genitourinary syndrome of menopause, or GSM.
Right. I was reading about the mechanism behind GSM, and this is where the biology directly and, quite frankly, brutally impacts physical closeness.
It really does.
Because it's not just about vaginal tissues thinning or basic dryness. The entire local environment changes its chemical makeup. Without estrogen, the pH of the vaginal secretions shifts dramatically. It goes from being naturally acidic, which protects against infection, to becoming much more alkaline.
Yes.
It essentially moves toward the pH of something like caustic soda.
That is an intense comparison, but chemically it illustrates the severity perfectly.
It's wild to think about.
It is. When that environment becomes alkaline, it suppresses the beneficial bacteria, which leads to chronic infections. But more importantly, for intimacy, that caustic environment means that any friction causes microscopic tissue damage.
Ouch.
Yeah. Leads to severe burning, irritation, and a profound, lingering physical pain.
So we have this biological fire burning, both neurologically and physically.
Yeah.
And the partner is watching the smoke, but has no idea what is actually causing it.
Exactly.
That is where the tragedy of misinterpretation really sets in. It's like the couple is reading from two completely different scripts.
That's a great way to put it.
Right. On one side, the woman is avoiding physical contact. Maybe she even pulls away from a simple hug on the couch because she is just physically exhausted.
Or terrified.
Yes, she's terrified that a hug will lead to an expectation of intimacy, and she wants to avoid having to explain the intense pain of GSM. She is in survival mode.
And on the other side, the partner is reading that exact same avoidance as a deliberate personal rejection.
They think, oh, she's lost interest in me, or she doesn't find me attractive anymore. Or in the worst case scenarios, they suspect an affair.
Yeah.
They internalize a biological symptom as an emotional withdrawal.
If we connect this to the bigger picture, you can see how this silent misinterpretation creates a rapidly widening gap in the relationship.
A huge gap.
The data shows that 38% of partners report feeling completely helpless when trying to support their partner through menopause.
Wow. Over a third.
And 28% say they end up in constant arguments purely out of a lack of understanding. The partner tries to step in, but because they misdiagnose the problem as emotional distance rather than a biological crisis, they use entirely the wrong tools to fix it.
So how do couples bridge that gap before the resentment becomes permanent? Because partners are obviously taking these changes very personally. Where does the communication repair actually start?
Well, it starts with knowing what not to say.
Okay, do tell.
One of the most destructive traps a partner can fall into is asking, when will this end? Or when will you be back to normal?
Oh, I can see how that would be frustrating.
Yeah.
But it sounds like a perfectly logical question if you view menopause as a brief illness like the flu.
Right, but it's not.
Exactly. As we established, this is a transition that can last up to a decade.
Hmm.
She doesn't know when it will end any more than her partner does.
Exactly.
Asking for a timeline just layers immense performance pressure on top of everything else. And the guidelines also strongly recommend that couples avoid making major, irreversible life decisions during this period of hormonal upheaval.
Which is very smart advice. Instead of asking for a timeline, the focus needs to shift toward structural support, specifically taking on more of the mental load.
Okay.
And we aren't just talking about doing the dishes once in a while.
Right. The mental load is the invisible labor. It's the cognitive bandwidth required to remember that, the kids have a dentist appointment next Tuesday, or that the dog needs its heartworm medication and that you're out of paper towels.
Exactly. When a partner actively absorbs that invisible labor, when they manage the schedule and the logistics without needing to be asked, they are directly targeting that overwhelming cognitive fatigue their menopausal partner is experiencing.
You're taking things off her plate.
You're clearing the runway, yeah.
Yeah.
Giving her brain the necessary space to process the massive biological transition it's undergoing.
And part of giving that space involves a concept the relationship experts call accepting the silence.
Mm-hmm.
And I found this fascinating. A lack of communication, a sudden quietness in the house, it isn't always a freeze out or a punishment.
Right.
Sometimes it's just a desperate need for quiet self-reflection.
That is a vital distinction, because menopause rarely happens in a vacuum. It often collides with other major life transitions,
Like what?
like children leaving the house, aging parents requiring care, or shifting career dynamics. There is a very real grieving process for the identity they used to hold and for the end of their reproductive years.
That's heavy.
It is. Silence is often just the external sound of intense internal processing.
But I want to push back on this a little bit.
Sure.
Because I think a lot of partners listening might feel like this is a trap. Realistically, if my partner is in physical pain from GSM or utterly exhausted or crying from a hormone crash, my instinct isn't to just sit there quietly and hold space.
You want to do something.
I want to find a cure. If someone you love is suffering, isn't it slightly patronizing to just listen? Shouldn't the partner be actively trying to fix the painful symptoms right that second?
It is an entirely natural, deeply loving instinct, but it is still the wrong tool for the job in that specific moment.
Okay, why?
There is a crucial difference between an acute injury and a chronic transition. When a partner tries to immediately fix the physical symptoms with unsolicited problem solving, saying things like, well, have you tried this supplement?
Right.
Or let's call the doctor right now.
Right.
It often feels dismissive of the emotional weight of what she's experiencing.
It makes her feel like a problem to be solved rather than a person to be understood.
Exactly. Validation must come first. Active listening without an agenda. Empathy, patience, and small, low-pressure gestures.
Like running a bath.
Running a bath, bringing a cup of tea, or simply saying, this sounds incredibly hard and I am here with you.
Yeah.
Those things are far more effective at rebuilding the foundation of the connection than applying pressure to, quote, solve the menopause.
So don't try to play pharmacist. Just be the partner. Let the emotional safety return first. But once that emotional communication is stabilized, couples still have to address the elephant in the room.
Physical intimacy.
Physical intimacy. Because as we mentioned with the microscopic tearing of GSM, sex often shifts from being a source of connection to a source of absolute dread.
The medical term for this is dyspareunia, or painful sex. And the psychosexual therapists outline a very specific and highly destructive psychological loop that occurs here.
How does it work?
When intimacy causes burning or tearing, the brain's fundamental protective response kicks in. The fear of pain actively overrides any biological sexual desire.
Makes total sense.
And that fear creates anticipatory anxiety hours or even days before you get anywhere near the bedroom.
And that anticipatory anxiety leads to total avoidance, which brings us back to why she might flinch away from a simple touch on the shoulder in the kitchen.
Exactly.
Her brain is mapping out the trajectory. Like, if I lean into this touch, it escalates to a kiss. The kiss escalates to the bedroom. The bedroom equals severe pain. Therefore, I must reject the touch on the shoulder.
The body is brilliantly, but frustratingly, protecting itself. Which is why therapists often recommend a completely counterintuitive strategy. Yes, temporarily banning penetrative sex altogether.
I love this concept, a penetration ban, because it entirely removes the performance anxiety.
It does.
If both people agree explicitly that penetrative sex is off the table for the next few weeks or months, then suddenly that ticking clock of dread is just gone.
Right.
You can cuddle on the couch, you can hold hands, you can kiss, without the terrifying mental calculus of where it might lead.
And it allows couples to utilize what is called the 3-sync method.
3-sync.
Yeah, it involves 3 deliberate steps. Feeling your own physical sensations, connecting with your partner's rhythm, and staying entirely present in the moment.
Okay.
The goal is to build intimacy solely through non-sexual or non-penetrative touch, massage, skin-to-skin contact, sensual exploration. You are slowly, safely retraining the brain's neural pathways to associate physical closeness with pleasure and safety again, rather than with pain and anxiety.
It's a complete shift in pacing. Like, think about it like cooking.
Okay.
In your teens and 20s, arousal is basically a microwave. You hit a button and you're ready in seconds.
Yeah, pretty much.
But during menopause, it's an AGA oven.
An AGA oven.
Yeah. For those who haven't used one, an AGA is one of those massive, heavy cast iron stoves.
Yeah.
It takes a whole lot of warming up, sometimes hours.
Oh, I see.
But once that cast iron is warm, it holds the heat beautifully and sustains it. You just cannot rush the preheating.
What's fascinating here is that couples who willingly embrace the AGA oven reality, who intentionally slow down, who explore new forms of physical touch, who focus entirely on the journey of connection rather than the destination of an orgasm, those couples overwhelmingly report a deeper emotional and physical closeness than they had prior to menopause. They learn to communicate their bodily needs in a much more vulnerable, authentic way.
Which is an incredibly hopeful takeaway. But we also have to acknowledge reality here.
Of course.
Sometimes communicating patiently and buying a new massage oil just isn't enough to combat severe hormonal deficit.
Very true.
And that is when it is time to bring in the professionals to tackle this as a united team.
Absolutely. And that team approach means the partners should ideally be attending the medical appointments.
Yes.
The brain fog we discussed earlier makes navigating a 15-minute doctor's consultation incredibly stressful. Having a partner there to offer moral support, to take notes, and to help remember the list of questions you wanted to ask is an invaluable act of solidarity.
And when you get into that doctor's office, the toolkit is actually extensive. We're talking about highly effective vaginal moisturizers, localized estrogen creams that specifically reverse the tissue damage of GSM without affecting the rest of the body,
Right. It's very targeted.
and systemic hormone replacement therapy, or HRT. But I want to pause here and ask you about a very specific hormone.
Okay, shoot. Yeah.
Because if you spend 5 minutes on social media, you will see testosterone talked about like it is a magical third component of HRT that acts as an instant zero-risk cure for low libido.
Oh, boy.
Is that the reality, or is that just internet hype?
It is largely internet hype and, frankly, dangerous misinformation that creates highly unrealistic expectations. The guidelines from the British Menopause Society are remarkably strict and explicit regarding testosterone.
So it's not just a quick fix.
It is not a casual lifestyle supplement, no.
Okay, what is the actual clinical protocol then?
First, it is only licensed to treat a very specific condition called hypoactive sexual desire disorder. And a doctor will only prescribe it after every other potential factor has been ruled out.
Meaning you have to rule out relationship resentment, chronic exhaustion, and the physical pain of vaginal atrophy first.
Exactly.
Because if sex hurts due to microscopic tearing, testosterone isn't going to fix it. Rebuilding the tissue with local estrogen will.
Precisely. If a doctor does determine testosterone is appropriate, the monitoring is rigorous.
How rigorous?
It requires a baseline blood test to ensure the woman's natural levels aren't already at the upper end of the normal range. There must be a clinical follow-up at 6 to 12 weeks. And most crucially, if the patient reports no improvement in libido after 6 months of use, the treatment must be completely discontinued.
Wait, why are they so strict about pulling the plug? If it's not working, what's the harm in just staying on a low dose just in case?
Because the risks of unnecessary use are significant. Exposing a woman to higher doses of testosterone than her body requires can cause severe and potentially irreversible side effects.
Irreversible? Like what?
We are talking about male pattern hair loss, a permanent deepening of the vocal cords, and clitoromegaly.
Let's pause on that medical term, clitoromegaly. What exactly does that mean in practical terms for the patient?
It refers to the abnormal physical enlargement of the clitoris.
Oh, wow.
Yeah, it can become highly sensitized,
Yeah.
physically uncomfortable, and the structural change does not always reverse itself even after the testosterone is stopped.
That sounds awful.
This is precisely why the medical consensus demands a strict monitored approach. It requires a biopsychosocial lens.
Biopsychosocial. Let's think about what that actually means in practice. You're saying that throwing a hormone patch or a testosterone gel at a failing marriage isn't going to save the marriage if you don't also address the emotional resentment that has built up over the last 3 years.
Exactly. You cannot treat the biology in isolation. You must treat the biology, the psychology, and the social or relationship dynamics simultaneously.
It's all connected.
It is. This is why therapy, specifically psychosexual counseling for the couple, is considered just as vital as the hormone prescription. You have to unpack the anticipatory anxiety and the communication breakdowns that is calcified around intimacy while the medication treats the physical deficiency.
So what does this all mean?
Good question.
If we synthesize the clinical guidelines, the hormonal mechanisms, the AGA ovens, and the communication strategies, what is the ultimate takeaway for you, the listener? To me, it boils down to this. Menopause is not a solo journey.
No, it's not.
It is the ultimate relationship team sport. It is a profound challenge that requires two people to stand together, look at a completely shifting biological landscape, and say, we are going to navigate this map together.
Beautifully said.
By understanding the very real chemistry driving the behavior, by responding with validation rather than unsolicited problem solving, by removing the pressure and redefining what intimacy actually looks like, and by seeking evidence-based medical help. Couples don't just survive the menopausal transition, they can actually use it to build a far more resilient, deeply connected partnership.
They absolutely can. And I'd like to leave you with one final provocative thought to ponder, which emerges repeatedly from the psychosexual therapy case studies.
I love these. What is it?
Culturally, we spend so much time framing menopause entirely around loss, the loss of youth, the loss of a prior identity, the loss of fertility.
Right.
But many women in these clinical settings describe their life and their relationship after the menopausal transition had settled as a, quote, dating superpower.
A dating superpower. That is a massive paradigm shift.
Think about the psychological freedom it offers. For decades, intimacy has been tethered to a ticking biological clock, to the monthly physical and emotional disruptions of periods, and to the ever-present background anxiety of an unwanted pregnancy.
That's a lot of baggage.
It is. When you remove all of that, could the end of fertility actually be a doorway? Could it be the beginning of the most liberated, adventurous, and deeply authentic phase of your sexual relationship?
Wow.
Once the hormonal chaos settles and the couple has done the work to reconnect, many find a freedom and a joy they haven't experienced since they were teenagers.
That is a phenomenal reframe. The music might have changed and the old choreography definitely won't work anymore. But once you commit to learning the new steps together, the dance can actually be better and freer than it ever was before.
Absolutely.
Thank you so much for joining us on this deep dive. We encourage you to keep exploring the material, to keep this conversation going with your partner, and we will catch you on the next one.